My name is James Baker. I'm a hand surgeon at OrthoSensi. I've been practicing medicine for about 14 years. Carpal tunnel is an extremely common problem. It's probably the most common diagnosis or second most common diagnosis that a hand surgeon in the community will treat. It's very common, both men and women. It can happen as a midlife typically and towards we get a little bit older. I was trained in residency with one of the original endoscopic techniques. I was trained very comfortably to do those in residency, but I was never quite convinced of the outcomes, and at the technique at the time seemed still a little premature, a little primitive, and had a little more risk than I was willing to accept. So I did a open or mini open procedure for the first about 12 years of my 14-year career so far. One of the main concerns was the safety of the procedure is always the paramount. And with the previous techniques, with the previous equipment, I never felt that the margin of safety was equal to open. The second thing was just the fluidity, the cadence of the surgery. It seemed a lot more involved. A lot of people were doing it under general anesthesia. It was a lot more expensive. And I just didn't feel that the potential improvements or recovery or speed of recovery was worth the trouble, so to speak. However, with the newer equipment, and the fact of something called Walant, that's W-A-L-A-N-T, which is wide awake local anesthesia without tourniquet or no tourniquet. This technique's been used in a lot of hand surgery over the last decade. It's becoming very popular. I do a lot of surgery that way now, and that's how I do my carpal tunnels. So we got rid of the anesthesia risk, the anesthesia cost, and now we have a system that's very fluid to use, very safe, and now I have enough patients of my own that I'm convinced that they recover faster. I would say the features of the retro device that caught my eye, that got me interested in taking a look at it, were the sort of one-step approach to the design of the cannula. So in most cases, there is no probing, there's no scraping of synovium, there's no dissection. The cannula itself, with one pass, does the work for you. The other thing is I prefer the retrograde cut. I like to see as I'm cutting what I'm cutting rather than the push cut or the antegrade cut. So that was a requirement. And then the cost and the ease of use of the equipment. If the equipment has a lot of complexity to it, it adds cost to the surgery center, it adds cost and complexity to the staff. So it was a very simple system. Another key feature of the AM surgical device, the Retra, is that once the cannula is in place, essentially the procedure is finished because everything is safe, the visualization's there, you can see where you're going to cut, and then the cut is made. Versus a lot of the other companies that I had tried previously, as you're trying to visualize where you're going to cut for safety purposes, the cannula itself is being withdrawn, and so you are trying to re-establish that, and that adds trauma and bleeding and all of those potential injuries to the nerve and the surrounding tissues. Whereas once this static cannula is in place, it's clear, you can see outside of it, you can see the nerve, you can see the tendons, and you can see the transverse fibers that you're going to cut. So once the cannula is in place, I mean, that's the end of the procedure in my mind. I think the product is well designed ergonomically. Once the cannula is in place, the device is of a size and of a length that the cords don't typically impinge on the drapes or the patient's shoulder. The cannula and the locking mechanism are all in one hand's reach, so to speak. And so you can literally stabilize the cannula with one hand, again, never moves. Patient doesn't have any discomfort. There's nothing once the cannula is in place. And once that happens, you can withdraw, look at the camera. You can actually even flip off the safety with one flip of the thumb or have a nurse do it. And then you can either antegrade or retrograde cut. So it's a very economic of movement device. So for the closure, I was never much of a glue user. I was always typically suture, and I was looking for something, given how rapid these patients were improving after surgery and wanting to get back to activities. A lot of them didn't even want to come back for their follow-up. So many of my post-operative follow-ups are done over video visits. And because of that, I wanted something that I could reliably use, that the patient would be comfortable with. Sutures that dissolve always have a suture reaction. The patients get concerned about that little bit of redness. So I typically will use a dissolvable single stitch below the surface and then just put glue on top. And I saw a technique that I liked and tried where you put a steri strip on top of the glue. And I think more than anything what that does is it keeps patients from playing with the glue because everyone kind of wants to pick at it and then the glue falls off and then the wound opens. So that kind of keeps them from picking at it for the couple days that's necessary. The recovery of an open carpal tunnel versus the endoscopic has always been debated, and I was definitely in the open is the same as endoscopic. I take care of a lot of workers and a lot of manual workers. We live in the central part of the country and there's a lot of warehouses and factories. And even with my open carpal tunnels, they were getting back typically around week 6. With the endoscopic, I find it's even faster. I would say it's at least a 2 to 3 week faster recovery with little to no pain. I don't even prescribe any narcotics. They take over-the-counter Tylenol or ibuprofen. So the recovery is very minimal.
We are AM Surgical, and this is AM Innovation.